we discussed yesterday. Do you have any questions about the basics of dilated cardiomyopathy? Nope, you're
I
good.
can't remember. Did we ever get like generalizations for like how dilated it is, like chamber sizes?
Yeah, I don't have a chart in front of me, but you're looking usually around 5.6 centimeters dilated as far as the view from terminal long axis goes. That's always going to be your first clue. That's why those numbers usually stick in my head a little better because that's your first clues. And it's they're usually generally pretty rounded as far as the transverse plane of the heart goes. So it's usually a pretty good representation. Then, of course, your next view is the Simpsons. Now, Simpsons, honestly, we don't necessarily keep memorized your volume per se, but we always look at the EF. So EF is kind of the main number you're looking at with Simpsons. But as long as you have a good trace and doing it in biplane in particular when it's an abnormal case. There's a lot of labs that only do their symptoms from the April 4 chamber view on a normal heart because it is normal and it's a decent representation and it takes less time to finish the study. However, when it becomes abnormal, that's when you up your protocol and start completing everything that you need to do. Just like on an aorta, if we came across a stenotic valve, then you start tracing the aortic flow as well as the LVOT for the VTIs rather than just a peak velocity. Peak velocity is just, it's a quick way to get us where we need to be when we're not concerned about stenosis. It's just a screening type of thing. So that's when an example of when you would boost your protocol and start doing a little bit more. As well as all those Dopplers, when they become abnormal, then even though right now we typically, and I think Tyler only has you measuring one waveform per strip, when anything becomes abnormal, you're doing a minimum of 3 consecutive beats. And then again, when it becomes an irregular rhythm, in addition to that, then you're doing 5 consecutive beats on each time that you take the strip. So those are things where you would boost your protocol to do a little bit extra once you find the disease process. So because otherwise it just takes a lot of time to measure and trace and measure and trace and measure and trace on every little thing. And it could take a lot more time during your exam. Good. All
I
right.
have a question, and I feel like it might be dumb.
No questions are dumb.
Okay, so under surgical treatment from the last PowerPoint, the part 1, it says that we would use mitral valvuloplasty or replacement. I understand the replacement portion. However, I don't understand the valvuloplasty because the whole issue is the annulus dilating, which wouldn't be a stenosis type plasty situation, right?
Right. So they usually will do they might need to go in and fix the valve. I mean, a valvuloplasty, I'm not sure how much it's going to help on a regurgitant jet unless the leak is coming from something structural that's kind of preventing it from closing properly. I just put it in there because that's what was in the text. I don't know. I mean, other than that, they are sometimes will do valve repair where they go in and actually kind of sew it up and kind of gather it and cut out sections of it and sew it back together and kind of gather it back in together. Which is also when they might do like the valvula or the rings, the micro annular rings and stuff like that.
So it's more like mitral repair and replacement instead of
That's,
valvuloplasty.
yeah, that's what I would believe to be true. Yes.
Okay, thank you. I was just trying to make sense in my head.
I know. Yeah, I mean, a valvuloplasty, like the balloon valvuloplasties and that, they will go in and balloon it out. And they do that for stenosis to be able to open it up. And it kind of tears open the commissures again because they're stuck together.
So I guess to go along with that, you wouldn't, or could you have a pre-existing pathology in the heart, such as mitral stenosis, and then develop dilated cardiomyopathy? Because then it would just dilate the annulus, right?
You could, but it wouldn't be diagnostically a dilated cardiomyopathy. It would just be a dilated congestive heart failure type of situation.
Okay.
Because there is valvular disease, that would be causing that. But at the same time, if it's mitral stenosis, it's more likely that we're going to have a smaller LV than normal anyway. So there'd be a lot of other stuff going on if that was the case. Yeah, and it can get complicated. It really does sometimes become, what came first, the chicken or the egg. So. All right, so just remember, take-home message for dilated cardiomyopathies. Again, it's a fundamental heart muscle issue that may be caused by one of several of those different options that we talked about yesterday. But it's sort of independent of valvular disease and stuff like that. And again, you will get valvular leakage, so valvular problems because of the dilated cardiomyopathy rather than the other way around. But a heart can be dilated for other reasons too. So, okay. All right, so here we go. So kind of continuing on, so the EPSS, so we're M mode of the mitral valve. That's always kind of our first clue that the chamber is big and or that the ejection fraction is low. So this is an indicator of reduced ejection fraction. Normal EPSS is 6 millimeters. So really anything over 7 millimeters as of the last 4 or 5 years is considered abnormal. When I was scanning, we always went by 10 millimeters. And maybe it was always that it was kind of small like that. It's just that we didn't really get concerned about it until it was 10 or more. Then we got to note that that was a big EF. Now, the exception to the EF is always if we have like an eccentric aortic regurgitation that's pushing that anterior mitral valve leaflet down or dampening its movement, it's not going to be applicable. And also when you have mitral stenosis, it's not applicable either. But other than those two examples, basically you want it coming up close to touching the septum. It can touch the septum totally during the time it's supposed to be open, which is in diastole. It should not be touching, as we'll talk about in hypertrophic cardiomyopathies, when the valve is supposed to be closed or in systole, particularly the end of that, because that's when we have that obstructive disease process, which can cause sudden cardiac death. So again, as it progressively gets larger, the ejection fraction becomes worse. So as you can imagine, the more and more dilated we get, the worse the ejection fraction becomes. So it's an indication or a secondary sign of a poor ejection fraction or systolic function. But obviously, if the chamber is dilated, those distances are going to grow. You might even see other signs, and you're going to see a big LV chamber in all the other views. All right, gradual closure of the aortic valve closes rounding of the box in M mode. So there's an example there of this. So as you can see, this box, so first of all, again, if you see anything super well in echo, what's your first gut reaction thought going to be?
Abnormal.
Something's wrong, right? You will learn in echo that sometimes you don't see what's going on, but you have a gut feeling that something's there, okay? I would say as an experienced tech that you need to trust your gut sometimes. And sometimes you're still not going to find the evidence you're looking for, but if you feel like something's probably not right, you need to go looking for what's wrong. Okay, you need to pay attention closely to the numbers, pay attention to what's happening. Because often your gut's going to lead you in the right direction. So I say that because if you see the valve really well, that might mean one of a couple of things. That is that either you've got a super easy to scan patients, which we know from adult perspective from our lab alone, good luck. None of us are that good of a scan in most cases. In a normal aortic valve, it's difficult to see the whole box, let alone the beginning of the box. So if you're seeing the box really well, again, it's either your super good window, we have a thickened valve, which in this case is true. And at the end of this in particular, then you're also seeing that it does. This is subtle, but this one kind of rounds off. You normally see like a box. We call it a box because it comes open. It's got pretty, acute angles and goes to a 90-degree angles, and then it shuts down just as quickly because of the rapid pressure changes. Why do you think in a dilated cardiomyopathy with systolic dysfunction, why do you think the end of the aortic box in M mode would be rounded?
Is it due to low cardiac output?
Yes. So there's simply not enough volume to hold the leaflets open, and the heart is weak, so it's not pushing it out super well. So the pressure from the aortic side is pushing back on it as it's trying to push the blood out still. It's still contracting, but it's starting to taper off just because it's not being able to overcome the aorta pressure. And therefore it shuts a little bit early. It doesn't come to a rapid snapping shut like it normally does. But that's kind of why that occurs. Okay, so the role of Doppler. Okay, so the assessment of forward flow. So obviously we do want to look at forward flow. We're going to be using the LVOT quite a bit to see the flow through it to get our kind of our stroke volume and our cardiac output. Now we do that on a routine basis. Could we do that through the middle of the LV? Yeah, technically, but there's just so much dynamics. You got a valve coming into it, a valve going out of it. LVOTs are just a good location that we can get perpendicular to for a good cross-sectional measurement that is an easy location to get an estimation of flow. And so we're always going to kind of use that as our place to look at cardiac output. And as we know, the VTI is going to be a little bit lower with those. So having the lower VTI indicates again that we've had less volume going out. That should be an indication, especially when you have a big dilated chamber, that the ejection fraction probably isn't super good. Now, the alternative to that is we got low blood volume in there, and there just isn't enough blood to cause that to happen. In that case, too, you can also get rounded of the aortic tips at the end of that M node. That would be an example of a severe bleed or something that you're getting an internal hemorrhage or something like that. But in this case, it's big dilated chamber. We already know that the ejection fraction probably isn't super great, so it would not be surprising at all to see a lower than normal VTI and peak velocity on the LVOT. All right. So those measurements will do that. Again, we're looking at diastolic functions. So anytime we've got systolic function, we also likely have diastolic dysfunction. So if our chamber again is very dilated, it's not all systolic problems. There's often some diastolic stuff. And as we know, diastology is all Doppler essentially. So again, remind me for diastolic function, what Dopplers are we looking at?
Mitral valve inflow.
Okay, inflow, good.
Pressure half time, right?
Okay, pressure half time will relate to mitral stenosis.
Yeah.
We're not
Pulmonary
doing
vein.
Deceleration time and
deceleration time, yes.
Pulmonary veins flow.
Pulmonary veins, good. Possible propagation velocity, tissue Doppler. What other thing did we miss?
Did you say TDI?
Valsalva.
Yes, Valsalva, good. Yeah, I did say TDI as well. So tissue Doppler, TDI, DTI, whatever the vendor has their system labeled as. Those are all things to assess diastolic function. And in addition, you could be looking at IVRTs and those more intricate measurements as well. Also taking into consideration, of course, things like your dilation of left atrium and things like that. So those things all contribute, but mainly when we're taking those Dopplers, we're looking at those main ones. Again, Valsalva may or may not be used super frequently. A lot of old school people probably will still do it, but again, it's technique dependent, it's patient dependent. So if they don't do a good Valsalva, you may not be getting good results. That's why, again, the tissue Doppler kind of reveals that. And as a quick review, also in diastolic function, how do I know when what are the grades of diastolic function, first of all, dysfunction?
So there's impaired relaxation, pseudo-normal, irreversible restrictive, or well, reversible restrictive, and then irreversible restrictive.
Yes. So yes, irreversible is definitely last end of the line kind of deal. But yes, and then we also could characterize those as grade 1, grade 2, grade 3, 3A, 3B. If we do that, some places may go grade 3 and grade 4, depending on how they want to say it. But again, that's kind of what we're looking at for the diastolic function. And what does diastolic dysfunction tell us about the walls?
That it's not relaxing.
Good. So not relaxing, it's less elastic. Therefore, everything kind of backs up with pressure and things like that. So very good. So that's essentially what all this table is showing you, is all those same things. And that's mainly left heart. What about the right heart? What if we're concerned about the diastolic function of the right heart? What can we do with that?
Tricuspid regurgitation.
Okay, so we'll look at the regurg. Is that going to tell us much about the diastolic function of the right heart, though?
Oh, would you measure the end diastolic volume of the PI?
You could do that to give us an idea of pressures. Yes, that may or may not be directly related to, it's really not directly related to the diastolic function. But you could
What
do,
about,
yeah, go ahead, Sarah.
what about TDI of the annulus
Yeah, you could do TDI of the annulus.
Or TR
and
block.
TAPSE?
Okay, you could do, let's see, on, so on the M mode of, or sorry, not the M mode, sorry, the mitral valve, we could do for systolic function, remember we could do a DPDT on the front side of that, the acceleration side of it. Remember I mentioned a couple of times that if you take the other side of the tricuspid regurgitation and do a DPDT there, that gives you an idea of the diastolic function of that chamber. So you could theoretically do that. I don't personally know anyone that does that, but theoretically you could use that same philosophy on the TR jet.
I have a question. Going off of what Sarah said, she mentioned TDI of the annulus in the right ventricle. I got a little bit confused when I was reviewing some of my material. Is TDI in the right ventricle, when we're looking specifically at the S prime wave, is that a systolic function or is that a diastolic function? Because I thought it was systolic.
If it's the S wave, that's systolic. If it's the E and A wave, you're diastolic.
Okay.
Yes, good. That's a good question to make sure that we're clear, because sometimes we just assume that everything is diastolic function because it's tissue Doppler, which is the place that we use it most often. But if we're looking at the S wave, that is an indication of systolic function also. And I believe on the S wave, you could actually trace that to give you an idea of the peripheral vascular resistance also in the lungs. So those are just measurements that could be applied. Most often are not applied, but they could be applied. Okay, so we do our pulmonary veins in the left heart. What do we do in the right heart? It's comparable to that.
Hepatic vein.
Good. Yep, hepatic veins. So let me jump back to tissue Doppler real quick. So in tissue Doppler, we on the left heart, where do we take our tissue Dopplers?
At the lateral annulus, well, and septal, but I think the lateral is the more important.
Yeah, I mean, actually both are. You'll often take both. The free wall of the left ventricle is going to be more specific to that. The septal wall is going to be a little bit more restricted because it has muscle bundles from both left and right heart. So in the tricuspid valve, which ones do you think would tell us relevant information to the right heart for diastolic function?
Lateral.
Yeah, lateral by itself, because honestly, if you're in the septal wall, and you're probably taking it anyway, because you're probably still looking at the diastolic function of the left heart as well. But you might also additionally take that lateral wall, and that will be more specific to the right heart. The septal is not going to give us enough information, because if the left heart's doing okay, it's going to override your signal of the right heart anyway. Okay, because it's a combination of both, and it's the septum is left heart dominant. Okay, good. So those are just ideas. You all know how to do TVI. Just looking at the picture here, so it's showing just kind of a representation with the formula. Tell me about the waveform that you see there. Is that normally how you see the LVOT? No. Which way do we see it usually?
Low baseline.
Down base, yeah, below baseline. But don't be thrown by it. It all really depends on where you're coming from. If I was doing if I was doing like a transesophageal echo, you could, depending on how you're approaching it, you could end up with one above the baseline. It just depends on where you transducer it. Remember that. But from our transthoracic perspective, that's not likely to happen. Okay, so this one is kind of an interesting one. Not really new per se, but it's a more understood nowadays. And as of the creation of this initial slide set, and it's this non-compaction is a disease process of the muscle where it doesn't, when the heart forms from fetal development, it doesn't compact against the walls. So it starts out as a bunch of little trabeculations that kind of become more compact and they form a nice tight muscle group as it develops. So it's a delay in developmental process that causes this non-compaction to occur. And ultimately it comes out with a whole bunch of little sinusoids and a ton of trabeculations, and the compact part of the wall is actually very, very thin. This was initially categorized in Feigenbaum as dilated cardiomyopathy, which is why I have it here. However, newer data and some of the stuff coming out, they're sometimes categorizing it as a hypertrophic cardiomyopathy because overall the muscle looks very thick. Okay, so I'm going to show you a picture of what that looks like here, both pathologically and in echo. But non-compaction is basically getting a bunch of little sinuses in the trabeculations that the blood can kind of go into, and it's a developmental problem of the heart.
I have a question.
A couple of years ago had that, or their child had that. Go ahead.
So is it the formation of new trabeculations, or it's just the tissue not like tightening up in areas?
Right. It never formed correctly. So it's supposed to come together and compact into a muscle group. Instead, it kind of leaves little gaps and holes between it all as it had that developmental process from early on. That's my understanding of it, at least. So it will probably make a little bit more sense as we look at it. Same thing when we go back to the tricuspid valve. You guys remember Epstein's anomaly? Remember what that is?
That's when the valve is displaced?
Yes, so it's apically displaced. It's an atrialized left ventricle, or right ventricle, excuse me, where it doesn't come down and it goes way up into the ventricle. Our attachment is more than 7 millimeters offset from our mitral attachment. And typically get tons and tons of tricuspid regurgitation, et cetera. That is another example of a developmental process where the valve leaflets kind of peel off the walls and they become the valve leaflets when it's in development. And what happened is it never peeled off the way that it's supposed to, and it's kind of again a delay in developmental process that created that issue. So again, when compaction of those trabeculations is supposed to compact, when that fails, that's when we get non-compaction. Nancy, you have a question?
Yeah, so I was just trying to think, like if the ventricle when it got made was like clay and you made a clay jar or a clay heart, right? And then you didn't fire it and it got all the blood in there, it kind of would erode it into big trabeculations. Does it kind of work like erosion and type of thing?
I think it's less about like erosion as formation. So it started out as this kind of stuff with a bunch of sinuses, and it's supposed to compact down into these solid walls. So not so much erosion, but more just lack of formation. Okay, good.
Wait, Scott, I have a question. So you said it happens when it's forming. It kind of sounds congenital, but then how could it not present until the person's 20s or 30s?
Well, typically they don't find out till then, because if everything else in the heart's actually pretty normal, sometimes it's not until somebody really pushes themselves, or maybe, I'll use my grandma as an example. So before she died, she never even got a driver's license. She never got out, never did anything. And, her safety was always just being at home, which is where she wanted to be. And she liked to cook and stuff like that. So that was her life. She never went out and exercised. She never went out and did all that kind of stuff. And sometimes, when she died, I suspected that she actually ended up dying of a heart attack, likely, and she probably had a lot of cholesterol buildup and plaque and stuff like that because it was in the family. Um, but I commented to my parents, it's like, we don't know that she really didn't have, because they're like, yeah, she's never had any heart issues or, vascular issues and stuff like that. It's like, well, how do you know that? Because she never pushed herself hard enough to try it. Um, and as a default, especially when you start stress testing patients, you're going to find that patients don't want to push themselves very hard. As a North American society, to be very honest, we're kind of lazy. If we can be in the lap of luxury, we're going to enjoy the lap of luxury. We're not going to push ourselves too much, right? Except those crazy people that go to the gym all the time. And so I think from that perspective, sometimes it doesn't reveal itself, not because it's not there, but more because they didn't notice because that person never really pushed themselves. Okay, when they do push themselves, that's when some of these things reveal themselves. And again, I'm going based off what I know of this. There may have been a lot more research in recent years into the details of this. Again, one of my students had a child that had this, and so she actually knew a fair amount about it because she was pretty passionate about it for one thing, but she was talking to a lot of the pediatric cardiologists and stuff. And this is one of those areas that kind of has a decent amount of research being done. And even to give you an idea, I mean, the cath lab stuff, I mean, Darren goes over a lot of pathophysiology. When I was going through my tenure process, he was evaluating one of my classes once, and we had this in there and we kind of talked about it. I never really scanned it at that time because I was, used to scanning in an adult lab. And he leans over to one of the students, or one of the students leans to him. He's like, "What's non-compaction?" And he's like, "I don't know. Ask Scott." So that's when we started really kind of looking at it in a little bit more detail, because in our industry, working with adults, we don't really see this very often. And yeah, so even Darren has been around for quite a number of years doing cath lab stuff. They don't see a lot of this. Okay, but it is out there, and again, the pediatric labs are mostly the ones that deal with it, maybe some adult congenital stuff. But it is kind of a congenital process that's causing it. Okay, so the ventricles in these cases don't have the efficiency to protect the ventricular geometry. In other words, they don't have that rigid muscular structure that kind of holds things together as it should. While we got the trabeculations, they are bunches of muscles and stuff, but they're not really working together as they should. And so the actual wall is actually quite thin and weak. Okay, so that becomes a problem that way. So if you're looking at actual volume, that's why they initially categorized it as a dilated cardiomyopathy, even though nowadays some of them may be considered a hypertrophic cardiomyopathy. Again, presents in early childhood or the second or third decade of life. And it's often going to present with arrhythmias because, again, if your muscle's not compacted the way that it should be, you can imagine our nerve tracts that run through there are specialized cardiac nerve tracts, like the bundle branches and stuff, are not forming the way they should either. And they're going to be more susceptible to manipulation and stimulation. Mike, you had a question?
Does the trabeculations also lead to like a larger presence of thrombus since we have lots of like smaller ridges in the heart?
Yeah, absolutely, possibly. Yeah, so if we slow the flow down, then yes, we have more places to attach and start thrombus areas. That's exactly right. When you're looking at it, especially pathologically, as you're going to see on the next slide, it kind of becomes what they call a honeycomb appearance. So let's just jump to the pictures. I think the picture says 1,000 words. Absolutely true. Okay. So again, if we're doing our quick down and dirty echo, this may look fine. Okay. But what you need to notice is these sinusoids coming in. And as even what you've scanned so far, you've noticed around the LV apex, there is more trabeculation going on, but there are more ridges on the tissue than actual, floating out in the fluid type. So if you're getting these sinusoids that go into the muscle, you should pay attention to that and see if you can get blood flow into it. So from what we've talked about previously, techs are typically not that good at optimizing your color Doppler to show apical flow. What did I tell you to do if you really want to show good detailed flow at the apex? What should you do on your system? Mike's talking to himself. I don't know if that's intended.
Was it color maps or focus?
Okay, I would not change the maps, but yes, you want to use your color. We definitely want to move our focus to the apex. Okay.
I don't remember. Oh God.
So think back to basic physics though. What things, what characteristics about your sound wave do you want to show detail, as much detail as possible?
High frequency.
High frequency, absolutely. So turn your color frequency to the highest possible frequency. Decrease your depth because that's going to affect your PRF on the 2D side of things. Put your focal zone at the apex. Use harmonics. Okay, typically we use harmonics as default, but in the old days I didn't. And then just kind of optimizing, keeping your color box over the area that's important. All those things will help to get the best possible detail in color that you can. Just remember to change your settings back to your normal color settings when you go to the deeper structures. But if you really want to show good spontaneous or good contrast in there with color, that's what you do. Okay. And in addition to that, if you really don't see it well, maybe your windows are poor and stuff like that, you should definitely be using a contrast and echo enhancing agent like Definity or Lumizone. Okay, that will light up where the blood pool actually is. Okay, does that make sense? Good. You also have the option of power Doppler, which is less direction specific and more intensity specific. So power Doppler could also be useful in that area. But 90% of your echo is the window. Okay, a good window first and foremost. Okay, and on the bottom here, you can see this is a pathology sample of what non-compaction looks like. So you can see all this honeycomb appearance, somewhat of a residual chamber there, somewhat of a chamber here, but you can see the blood would get into all these areas. Look how thin the actual wall that's compacted is. Okay, if I had a super thin wall on an artery, what would you suspect might happen?
Rupture.
Pop.
Yeah, at least an aneurysm, right? So dilation, aneurysm. So same thing on the heart. If we get the weakness of those walls, if we get the pressure inside there, it's going to possibly expand out and create problems. So these kids often have, I'm going to say kids because usually it is when they're young, but it could be in their 20s or 30s. They're going to have ejection fraction issues. Their systolic function is not going to be very good as far as the effectual movement of that. And it's going to be weak overall. So this student whose child had this, she actually was a cross-country runner. She really enjoyed running, but she would become cyanotic as she ran. Okay, so it's affecting the flow and the dynamics of the heart very, very significantly. You know, they would obviously stay in close contact with their cardiologist so they knew how far they could push it. But it's taking a risk pushing somebody with this condition in athletics. So it's kind of one of those you're going to have to engage with your doctor what's appropriate. Okay, we already kind of covered the whole diastolic dysfunction thing. As I'm looking at these Dopplers, I will quickly comment that don't overgain, especially your tissue Doppler. That is a very, very bright tissue Doppler. It should not be that bright. The rest of it we kind of talked about. And again, just showing diastolic dysfunction overall. This is not non-compaction. This is just general diastolic function. Those are just the waveforms and stuff that you take to obtain that. Those are really crappy pulmonary veins. Sorry. that's a poor example of pulmonary veins. Okay, again, just rehashing the waveforms and stuff like that. So we're looking at the filling pressures in the left atria. You're comparing the E wave, the velocity of the E wave through the mitral inflow to the tissue Doppler. So it's dividing the inflow from the velocity of the E prime, which is your tissue Doppler. It should be greater than or equal to 15. Would equate to elevated pulmonary wedge pressure. E to E prime less than 8 or equal to 8 is a low left atrial filling pressure. Everything else associated with a broad range of filling pressures. A dot on the wrong spot there. Okay, propagation velocity again, just to again reiterate. So again, put your color Doppler on first, like it is here. Run your M mode from the apex on the 4-chamber view through the, and it could be a 2-chamber view also. Run it through the tips of the mitral valve leaflets. Again, what you're seeing here is during diastole, the flow's coming into the ventricle. It's red overall, but we get aliasing, which goes over to blue. And we're measuring, this again is your mitral valve tips here. That's the mitral valve. When it's open and you don't see that line, again, closed, you see the line, open, you don't see the line. That's when the flow comes in, and we're looking at how long it takes to get from here out towards the apex, okay? And we're just measuring the slope. Now this line that they've got there should actually be, you actually place it right on the aliasing velocity. So I'd actually put it on the border of the blue and red. They've got it slightly to the left. It's not quite where I'd measure it. The other one shows a less of a slope, which is going to show for poorer function. All right, enough said on that. Myocardial performance index. So again, this is just how well it's performing. And we're going to take into consideration the overall time. And we're going to compare the IVCT and the IVRT to the actual outflow, or the ET, which is ejection time. So the MPI is just taking the total of everything minus the ejection time. That essentially is like adding the IVCT and adding the IVRT together to divide the ejection time on the baseline. So that's what the myocardial performance index is. Normal for that is 0.4 or less. And as a note, this is just my personal, not a pet peeve, but a preference, my OCD, I suppose, kicking in. And just for accuracy, if you're reporting numbers with a decimal, just as a mathematical habit, always put a 0 before the decimal, because if you're especially handwriting a report and you just put point this or point that, the doctor or whoever's interpreting that may not notice the decimal, and that significantly changes what it is. So just as a mathematical habit, always put a 0 before a decimal.
Scott, I have a question.
Yeah, go ahead.
How much of all of these values do you remember? And how long did it take you to really get to a point when you were scanning that you remembered all these values of normal?
Honestly, you, unless you do it all the time in your lab's going to have 2 or 3 main things that you look at. Anything else is going to be a table in a book that you look up, or it might be a table on the wall that you have in your lab. But typically your lab is going to narrow it down to the most common measurements that you're going to take, just as a quick down and dirty. And then if you have issues, and keep this in mind when you're scanning, if you really think that something's going on and you're kind of splitting hairs with your other numbers, and you want to do a measurement like this, it's totally appropriate to do it. But sometimes I'd tell the patient, like, I just need to go check some pictures real quick, just make sure they got across, don't get them worried about anything, just let them be safe and stable there. And you can go out to the room and check the book, check the numbers, whatever you need to make sure that you have what you need. But you want to make sure you have what you need before you're finished the exam. Now, in a hospital situation, that could be a little bit different, because you might be in the ICU or somewhere else. The pocket reference, as you can imagine, this would not be super comfortable in your pocket. Okay, the original version of this was designed to be able to fit in the side of your little side leg pocket of your scrubs. Clearly, it's not that way anymore. It wouldn't hurt though to have one of these, maybe even on your cart. And then if you needed to, on your ultrasound machine, then if you needed to, just kind of pull it out and step out of the room for a minute and maybe look up stuff and make sure that you're getting what you need. But honestly, the MPI, from my scanning experience, that's something we never did in our lab. Some labs might be doing that. Some of these measurements, you could ask Tyler how much he used it. I'm doubtful that it's a very commonly done measurement. Kelsey, go ahead.
Yeah, so that's what I was going to ask. I was like, how often is MPI done? Because we've also mentioned muscle mass and MAPSI, which I've also heard you and others say that's also not something done.
So MAPC is not done very commonly. MAPC is a newer measurement, so it's an indication of systolic function. If it's done on the free wall of the LV, that's going to be left ventricular function. The TAPC is on the right ventricular. That one is done almost all the time in labs because we don't have a lot of measurements to show function of right heart. So that one they do a lot. That's a fairly new measurement. That's an easy one though. It's just a simple, straight up and down, for placing the caliper accurately and stuff. Dampen your gain, stuff like that, just to accentuate what's going on. But that one's a pretty easy one. It really depends on your lab.
Scott, did you say MAPC was systolic function?
Yes.
Okay, thank you.
So what it indicates is how much the annulus is moving towards the apex during contraction. So we want to see that move a lot. That's going to show good systolic function. As you can imagine, if the muscle is not working very well, it's going to pull up just a little bit. Okay, so you're going to see it rise just a slight bit, but usually you're going to see a little mountain of data that goes with that, and you want to see good movement for good function.
But can't you just measure the S prime with TDI instead of using MAPC?
You can measure the velocities of that. That may have some correlation, but most labs have found that for TAPC, they're finding that TAPC is quite a useful measurement. It sounds like most labs are doing that.
Oh, right, because TDI of the annulus is a velocity versus a distance for MAPC.
Yes, correct. But there is still a correlation. The more it moves and the faster it moves, that can tell you some diastolic functions or that's systolic function. But it could tell you some of that as well. But I think there's better data for the M mode of the TAPC. I kind of taught because that was a new measurement when I started teaching here. I kind of taught the MAPC first because it was easy and we're used to getting a decent LV, and it was harder for students to get a good RV free wall. But the concept is very much the same and it's very easy to do. So I just kind of did both, but most labs only do TAPC. All right. And again, so looking at this flow, so to get it from a spectral Doppler perspective, how do you set up your, what view do you look at it from? And how do you obtain this view so that you get both the mitral inflow and the LVOT flow? Yeah, so an apical perspective has to be the perspective where you actually see either a 5-chamber or a 3-chamber view, because it has to be capturing the flow going out the aorta. If you're using pulse wave, which you can do, just make sure that it's capturing both of those signals. If it's a CW, just make sure that your line runs through an area to grab both signals. So it's not super complicated to do. Just make sure that your Doppler is capturing the right area and you can see the waveforms.
Is it essentially just an IVRT placement, basically?
Yep. Yeah, if you're to do a good IVRT, you've got what you need to do it. Yeah, that's exactly right. Again, if you're doing IVRT regularly, you've already got the data, you've already got the image. It's not hard to add that as a myocardial performance index. So just remember that that's going to apply to the function of it. Okay, so renal disease. So we're going to get more into specific pathologies now that might be contributing to dilated cardiomyopathy. So long-standing renal disease, we get concurrent metabolic abnormalities and hypertension, which results in annular calcification with marked LV hypertrophy. So if you know, this is, again, sometimes we are not that interested in other organ systems of the body. When a patient comes in, you ask them for their pain and they're talking about this pain in their toenail or some stupid thing, and you're like, that doesn't even relate to what I want. So we need to make sure that things are relevant, but sometimes we don't want to ignore other organ systems, particularly kidneys, because they could have some indication to us that something is going on, and it might help to give you that full story of that patient and see what the actual disease process is. And again, that's why doctors, you should always respect the doctors, because while we may be very good at doing echo, we're not very good at knowing the pathophysiology of the rest of the body. Okay, they're the ones that know what's going on with the whole story, the global picture. And so, yeah, so we talked about having annular calcifications because of longstanding chronic renal disease or renal failure. And again, it's going to have a bunch of metabolic issues, blood pressure issues, and stuff like that. And it may also have then the hypertrophy. LV dysfunction and CHF are present due to a combination of metabolic effects, and that affects the long-standing hypertrophy. We can show improvement in individuals after transplant or aggressive dialysis. So in other words, we can, we're not going to do anything different in ARACA. We're still going to do ARACA the same way. But if they do give aggressive dialysis to a patient, meaning that they're filtering out their blood, cleaning the blood out, and putting it back in, or if they have kidney transplants that are now functioning properly, therefore correcting these metabolic deficiencies, that puts it back into balance, and we might see an improvement in ejection fraction and function of the heart. Kelsey?
When patients are on dialysis, would that improve their preload?
It could. Yeah, so with the kidneys, it doesn't necessarily, so if you're looking at total body blood volume, it's not going to change anything. It's just simply going through the filter. Okay, it's going to affect possibly the pressure inside the arterial system because maybe it's not filtering so well. The problem is it's not filtering very well. But that might just continue all the way through, goes through the afferent and efferent arterioles, goes through the glomerular system, and it doesn't filter the way that it should. But the problem is that it's leaving the metabolic particles that should be removed are not getting removed, and therefore it throws off your acid-base balance. It allows those toxins to remain in the body, and that becomes cardiotoxic after a while as well. So really, the bigger issue that we're having with chronic renal failure is that those toxicities that are still in the blood are affecting the systolic function overall.
Okay,
So,
yeah, because I knew the function of dialysis. I knew what it did, but I never really understood how they set the rate of filtering, like if it made the heart like contract better to reduce the preload, that's a result of cardiomyopathy.
yeah, during the dialysis, I'm not sure about that. I will say that the body doesn't tolerate rapid changes of any kind very well. For example, when we have patients that have pericardial fluid, or not pericardial, but abdominal fluid, ascites, when they've got ascites of a significant amount, you would think that drawing off as much of that as you can when you do when you drain it out, you would think that would be very good. And I forget the numbers now. I used to know them, but I think it was like we had a patient once that we drew off, like, no joke, like 17 liters of fluid off their abdomen. I mean, a massive amount. Okay. I think the limit is like 11, that you want to do in one episode. So they would still have quite a bit of fluid left over. But if I rapidly reduce that much volume, think of the hemodynamic changes that's now occurring to the body. You just changed all of the pressure settings essentially of the abdomen, which is going to affect the heart. So you can actually, by drawing off too much of that bad stuff at once or too quickly, you could cause the patient to go into heart failure. So they do have to have a balance, even though those are very bad things. They have to balance how they do that. It's crazy. Yeah, chronic renal disease patients, man, that's not a life I would want to live. It's miserable.
Do you know like how long they would have to wait between sessions for their body to acclimate to the new like abdominal pressure?
For the ascites, I'm not sure, probably a day or two. Okay, so usually a lot of those patients are cancer patients. So almost anybody with ascites has cancer or chronic cirrhosis of the liver. Both very bad situations. You can do that fairly quickly. Renal disease patients that are on dialysis, they are often in like every 3 days. Okay, so they come in every few days to get that done. They'll have like maybe a 24-hour period where they feel decent, not good, but decent. And then most of the other time is just, I feel like absolute crap. Not a fun line. All right. All right, basic and advanced therapy. So our big thing is to identify when there is dilated cardiomyopathy there. Again, to diagnose dilated cardiomyopathy, we need to rule out other valvular type of disease processes and things like that. So we're going to detect it. We're going to look at the systolic function, and then they're going to treat it accordingly. Restrictive, so if they get restrictive physiology, which is diastolic function stuff, that identifies end-stage disease and needs aggressive therapy treatment. So we're talking probably restrictive, reversible at this point, okay? At some point when it becomes irreversible, it doesn't really matter what we do, that's very end stage. Okay, there's really nothing that they can do to fix that. When it's restrictive, along with other parameters, may identify subsets that are likely to be volume overload patients who need aggressive diuretic therapy. So again, heavy on the medications and stuff like that to try to reduce the workload on the heart. Pacing. So if we got a dysynchronous heart, what does dysynchronous heart mean?
Beating out of beat.
Yep, out of rhythm. Is often a left bundle branch issue. Remember, as we talked about EKG, a left bundle branch is never really normal, whereas a right bundle branch can sometimes be a normal variant. Okay, but left, if we're seeing that, is not. Inefficient heart contraction and therefore reduces ejection fraction and causes remodeling that causes the dilated cardiomyopathy. So again, I've used remodeling in two senses. In the negative sense, it's if we don't do anything about it, it's getting a worse geometric shape and less efficient on our ejection fraction. And if we pacemake it, if we pace it properly and we rebuild those walls, we can actually improve that. So we can get a positive type of remodeling. We only do this on patients with marked or significant mechanical dyssynchrony. Otherwise, they're not going to benefit a whole lot from it. And echo can be used to identify this stuff. Back in the early 2000s, when I was scanning in Colorado Springs, I actually got to work with, we worked with a pacemaking group, so they did the pacemakers. Now those implanted pacemakers, they have this wand and hooked up to a computer that they kind of put over top of the pacemaker, and that's how they change the settings, okay? It's really kind of cool. And we actually used to do Dopplers. We do like a mitral inflow Doppler to look at how the function is. And we'd use M mode and we'd look at the timing of the septal wall to the posterior wall, and they would be off. They'd be squeezing at two different times. They'd be dysynchronous. And they would put the wand over the chest. They would often disable the pacemaker initially to see what the native rhythm is. And so, I mean, we're sitting here in the room, you're scanning the patient, and instantly, as they change that, they go back to this weird abnormal rhythm. The patients become very symptomatic quite often, like immediately. And you notice that change right away. And we're seeing it in the E and A wave, and we're also seeing it in the timing of the wall contraction. And and then they tweak their settings, they make a few adjustments and activate it, and then all of a sudden the patient's like back to normal. It's just the weirdest thing because you're watching this patient in real time go very symptomatic to normal, and then what we do is we try to bring it to the most normal pattern. So, you know, your E and A wave may get far apart. If there's AFib, you might not have an A wave at all. But sometimes your E and A wave gets so close together that it kind of fuses to be one. And sometimes you're cutting it off where your timing might become too close to the next contraction and you're cutting off the actual flow. And so you have to time all those things so that they're most normal looking. And that's when your patient is asymptomatic and in an optimal position. So it's kind of a cool, if you ever have the experience to be involved in that, it's kind of a cool thing to watch and be part of. At those times, we're thinking that echo would play a big role in electrophysiology. The reality is electrophysiology has gone a lot more into the invasive cardiac world, and they can do so much with the pacing. And I'm not sure how much they even involve echo anymore in that process. But it's cool when you have experience to do it. Here is, this is using strain imaging to compare it. So they're actually taking these two samples right here. One is the yellow one. This is representing the yellow line. The green one is on this far wall. Now they're not exactly opposite of each other. They should technically be opposite of each other, not at different levels from base to apex. They're kind of slightly different. But what you're seeing here is the timing of these events. So here's the peak of that wall in the septal wall. Here's the peak of the one on the lateral wall. As they time that and pace it correctly and change the pacing, they essentially want walls directly opposite of each other to squeeze at the same time. So these peaks would then line up in one position rather than in two different times. Okay, that would show us that we have synchrony and not dysynchrony.
So Scott,
Yeah, go ahead.
in this situation, the lateral wall has some sort of electrical problem, or like, how would you say, what is the problem?
There is an electrical problem. We're not, from this one picture, I can't say which one it is for sure. All we can say is that the septal wall is squeezing earlier than the lateral wall, which is, they need to squeeze at the same time. Okay, so that's all we can really say about it. Now, if I was to take a sample here and put one at the apex, they should contract at different times because the apex should be squeezing first and then kind of pushing the blood out that way. If my basal wall is squeezed first and then pushed the other way, all the pressure and fluid then goes towards the apex, causing a possible formation of an aneurysm. So it definitely needs to contract in the right pattern, but the walls opposite of each other should contract at the same time. Here's another example is what I was talking about with the M mode. So we run our M mode through peristernal long axis view, just like we do to take our walls, but you can see that this has a very early contraction here. And then our contraction in the posterior wall is way over here. So what we do is we measure what we were doing in that lab is we measure the peak of the systolic contraction on the septal wall to the peak of the systolic contraction on the posterior wall and compare those in milliseconds. So this is taking a slope. It's, remember, you got distance over time, but we're looking for the time that this goes to the time that that goes, and we're looking at that time difference, and we want to bring that closer together to be able to have a more efficient contraction. Kind of cool stuff. Again, just a couple of waveforms that you can see. Here's our normal E and A waveform. This is what it looks like when, first of all, the E is shorter than the A, so therefore we know we've got at least impaired relaxation. And these waveforms are starting to merge on each other. I've got a diagram coming up in just a second that will help us see that a little bit better. But echo, again, can be used to help optimize that. Now, we can't do anything in the echo itself. We can simply look at the evidence that's there, and the pacing people will make adjustments to the pacemaker to adjust that accordingly. So the pacemaker in these cases do not allow for native pacing. So it doesn't let the heart do the contraction on its own, it's doing it all the work for it. We shorten the AV interval to supersede. If the AV interval is too short, it will compromise the diastolic filling. Ideal is that the AV interval allows for clear discrimination of E and A waves. So like up here, we've got clear E wave, clear A wave. Even here, they're fusing together, but you know, they could be further separate, but we still get a lot of patients that are like this that can still function okay. And again, the A wave in this case on the right is slightly encroaching on the, it might be encroaching on the QRS. If it gets too close to the QRS and we start cutting off the A wave, then you're restricting the amount of flow going out during diastole. Echo can monitor the mitral valve. We look at the EF, the TBI, the LVOT, and we can look at the severity of MR also. The next one here is kind of a diagram of, so if they're adjusting these pacemaking and stuff, you're going to start to see some of this stuff. So here's your optimal. We got a clear E wave, clear A wave. They're in good timing. It's not being cut off. Remember that there's, from the time that our QRS happens, there's an electrical event that happens and a slight delay before the mechanical event happens. So you do have some, you know, while we got our pace, or we got our A wave here, it's not cut off because the actual contraction didn't happen until just about the end of that QRS, and then it starts the cycle. So that's normal.
So Scott, can you show me where the AV interval, like point measurements, are supposed to be at?
So, so we're looking at, so here's a too long of a delay. So E wave is from basically just the residual back pressure opening up and stuff like that. So that's just the mitral valve opening residually. The A wave, remember, comes from the P wave kick, okay? And this is where our AV delay, so the atrioventricular delay, if we don't have enough of the AV delay from the P wave initiation to the QRS, that will affect the A wave flow. So it could be cutting off the amount of flow coming out. So the bottom example is too short of an AV delay, and you can see the A wave gets pushed out further. The P wave comes almost right onto the QRS, so their timing is too close together. So that the AV delay we're talking about is from the beginning of the P wave to the beginning of the QRS. That will cut off the flow from the A wave. Too long of a delay, you might get these merging together. So we're actually moving. So the E is where it is. And what we're doing is we're actually moving the A wave earlier, and it's encroaching on the E wave. So that's where those waveforms start to merge together. And then you might get some diastolic MR in that case as well if you have MR. I'm not going to say for my test, I'm not going to test like in super detail on this, but I think it's quite helpful to kind of understand this process at the same time. Okay, so for registry, you might at least revisit it and try to understand it at some point. All right, transplantation is our final option. It's important to recognize the anticipated appearance of the heart post-transplant. So in other words, if I did like a bypass graft and vascular, what do I want to know about that procedure when I scan it?
I'm sorry, can you state your question again?
Yep, and Sarah and Kelsey could, either one of them can answer this since you're vascular tech. So if I'm scanning a patient that has a bypass graft in the leg, we'll say, what do I want to know about that before I do the exam?
Where it is.
Yeah, what kind it is.
What kind it is, where it attaches, all that kind of stuff. You want to know that stuff because what do you have to do when you scan it?
Follow it.
Okay, you gotta prove that there's flow in it. You got to prove that the opening is open. You got to prove that the distal end of it is open as well. So you need to see flow through it, and you need to see the anastomoses where they're attached, right? And then sometimes you might show the native area, but that's kind of irrelevant at that point, to be honest. And then we look at the flow before it and after it to make sure that that wasn't compromised. So the point is, when they do a procedure, you want to know what was done, because when you go to do the exam, you need to prove where those attachments are done. And we're looking for places where maybe it's leaked out or there's problems occurring because of it. So often a lot of the failures come in the area where it's actually sewn together, okay? Because of inflammation, because of rejection, there could be a whole bunch of different issues with that. So the heart is no different. So you want to kind of know what was done exactly so that when you show your pictures, you're not thrown off by these weird appearances of things like stitching or really super long atria or something like that that kind of throws you off. It's like, oh, this is totally abnormal, and you didn't know that they had a heart transplant. All right, so historically they're attached. So the old school way of doing it is they attach via the atria. So both atria bilaterally would be large. That preserves the connection of the pulmonary veins, so they don't have to reconnect those tiny little veins. They just do it in mid-atria. Currently, and more commonly nowadays, they do bicaval of the right atrium. So the right atrium will initially be small. Okay, so it's normal sized right atrium because that came with the transplanted heart. And instead of attaching in the mid portion of the atria, they actually attach on the IVC and SVC. So if you can see those, you want to see where those attachments are, because that's where problems could occur. Both of them result in large left atria. So both of them, regardless, are going to have large left atria. Sarah, do you have a comment?
Yeah, bicaval, can you explain what that is?
Yeah, bicaval is inferior vena cava and superior vena cava.
Okay, thank you.
Just means that we got both of them in the view. And in fact, we do the bicaval view subcostally, and we're actually looking at both the IVC and SVC through the right atria. All right, so depends on which type was done. So if you have the old school way, you're gonna have two long atria. If you have the new school way, you're gonna have a smaller right atria and a longer left atria. Now I don't say big, I'm saying long because they are attached mid atria and they appear to be longer, not necessarily wider. In addition to that, you might actually see where it's sewn together. So you might see little nodular type bumps on the walls where it connects, and don't mistake that for a mass or a thrombus because it's just a sewing of that tissue together. You may see poor functionality of the right ventricle due to the process and existing pulmonary hypertension. So it might have some issues still. TR is common because of repeated right ventricular biopsies. So in the right heart, when we covered that last quarter, we mentioned that if they're doing biopsies quite regularly, that damages the tissue of the valve and that can scar it and cause some regurgitation to happen. I always get calls during lecture. What's the deal with that? All right, so transplant and rejection. So while we do transplantation, we know that tissues of different tissue types, if it's not well matched, is likely to cause rejection or deterioration of the tissue and failure. Even in a good tissue match, you can still have that happen. They're going to be on a bunch of medications to help prevent that. So those are things that we need to consider. So attempts have been made to use echo to evaluate rejection, but it's not as good as doing a biopsy. So let me put this thought out there on that statement. So that classically is true, that biopsies are going to have pathological evidence of rejection occurring. We may not see that in good function stuff as we see it in echo, but it's usually pretty advanced by the time we see it in echo. What modality within echo can we use, or what software or technology can we use within echo that might tell us earlier than any other? Doppler?
For rejection?
Yep. From what we've talked about, what we can see stuff happening earlier than any other technology, what can we use in echo that will give us the earliest clue?
Wall motion abnormality?
Yeah, so strain imaging, that's right. I think I heard that.
Yep.
Yeah, you could use strain imaging, might give you an earlier clue that something's happened. So even though that may not be your protocol in your lab, if you've got that technology, you might use the strain imaging to help prove that. Just putting it out there. But yes, they're likely going to do biopsy if they have any real suspicion of that occurring. We're also going to be looking at fluid collections and stuff outside the heart, any abnormal appearance of that tissue, especially around the anastomosis area. You're definitely going to be looking at diastolic and systolic function issues because if it's reacting and it's inflamed, you're going to have issues with it that way. Now, often when patients have inflamed heart issues, it's very painful. Okay. What do you think is, so if we have myocarditis, for example, and the myocardial tissue is inflamed and swollen, that's often quite painful and bad effects. With a heart transplant, is that going to be the same?
Wouldn't it be the same?
So the reaction of the tissue itself will be the same, but the body's ability to detect that pain is the same or not?
Oh, is that the whole denervation thing on your slide?
Yeah, because we cut the nerves off, you ain't going to feel it. So they might feel symptomatic, but they're not going to feel the pain part of it. So these patients, you have to keep in mind that that is a real possibility. So you need to be looking for signs of poor function and stuff like that because the heart's not giving the body the feedback. Okay. So acute rejection can show signs of pseudohypertrophy and systolic dysfunction. And again, that pseudohypertrophy is because of inflamed muscle. So it's going to look thick and it's going to have poor function. Okay,
Can I ask you a question on the denervation piece?
Mm-hmm.
Eventually, will those nerves grow back or reconnect or anything?
They will not.
Oh, okay.
Nope. Unfortunately, it's sort of like a diabetic neuropathy. Once they have it, it's permanent.
So like if they have a heart attack, they won't know it.
Possibly, yeah.
It's
I mean,
crazy.
they won't know it from the pain perspective. They won't feel that neck and jaw pain or whatever other presentation that comes. They will just have symptoms, low ejection fraction. So they're going to be symptomatic in other ways, but not with the pain. Similar to diabetic patients, again, once they become, they get diabetic neuropathy, they also don't feel pain the same way that the rest of us do. So they don't get that natural feedback. Okay, so that's only seen in severe cases of rejection where that muscle becomes significantly inflamed and hypertrophy, or that pseudo hypertrophy. Chronic, they might have serial evaluation of LV systolic function. So every time they come in to see us, we're going to look at the systolic function. We're also going to look at the diastolic function. Again, don't be surprised if you're using strain imaging as one application for looking at rejection. Okay, I think that's a very reasonable use of that technology. There's going to be an accelerated rate of coronary atherosclerosis.
I don't know the question.
So that's kind of interesting. Sorry, Nancy, you have a question?
Yeah, we have a question.
Sure.
So Darren was talking about this a little bit, but since there's no nerves connected to the heart, is it still regulated by baroreceptors? How does the heart rate go up and down with exercise? Or do they have to put in a pacemaker?
I don't know if they put in a pacemaker. I think they use the heart's natural pacing. There is going to be some influence on baroreceptors because those baroreceptors are in the carotids and the kidneys. And so that inherently is going to affect how the brain tries to go. But I'm not sure what it does, honestly, on pacing the heart. I believe it goes on its natural, SA node, AV node system. I'm not sure. They might pace it. I'm not sure. I personally haven't scanned a lot of transplanted hearts. I've scanned a couple, but not enough to really know that. Maybe ask Darren that question too as you talk to him again.
Yeah, and let us know. I'm so confused now.
Yeah, did they, yeah, because there's no way for it to, let's see. Yeah, I don't think there's really a way, I mean, other than constricting and dilating and stuff and vessels and stuff like that. So the brain can affect the afterload, but I don't think there's really a lot it can do other than just relying totally on the pacemaker, the heart. So if they've got another pacemaker implanted, they can certainly control it that way. Obviously, a transplant patient is not going to be out running marathons either. When they get a transplant, that doesn't buy them 35 years of life, likely. I don't know how long it will last, but these patients are not going to be bouncing back to a full activity. At that point, they're happy to be alive, which they should be. So there is an increased rate then in atherosclerosis development in transplant patients. So it's called transplant vasculopathy. So I don't know why that process is, but they develop plaque faster. Transplants are clinically silent due to the denervation. We've already talked about that. Percutaneous biopsies are used for evaluating the tissue rejection. But again, if you're doing the echo and you've got strain imaging and stuff like that, it might not hurt to throw it on. Just make sure your doctor knows what your crap you're doing and like, what are you doing? Maybe you can start a new way of doing things. Be awesome. Okay, LVADs. So we talked about LVADs. So it's used where transplant is not an option, or if they're holding up to the very last minute. It's for who mechanical support is the only option. Again, it's just going to keep them going for a while. Be aware of the appearance of it. The ventricle will remain dilated, but not to the prior degree that it was dilated. And it will appear to have contractility. So it's kind of weird because they actually do contract and stuff, but the aortic valve doesn't open because the fluid, instead of going out the aorta, is drawn down through the apex and pushed around the aortic valve. Mitral valve opens and closes, but the aortic valve does not. Look for large bore cannula. So a large thick cannula comes in at the apex, and we're going to evaluate that to make sure it doesn't get collapsed or is pushing up against tissue. Yeah, Nancy?
So this is Casey's question. So if the aortic valve is basically closed all the time, doesn't it like die? Dry out? You know, how come it doesn't
Yeah, it doesn't.
wither away?
And sometimes it could open. I mean, it's basically is held closed due to pressure. Could that develop into irritation and possible fusion of the leaflets of the commissures? Possibly, yes. It doesn't totally, because the valve itself is pretty. It's a pretty fibrous tissue with a very light layer of like epithelial type cells on it, like the simple squamous cells. And so, yeah, it doesn't. And again, these are basically terminal patients too, keeping that in mind. Again, you're not expecting a life expectancy of 20 years after they implant one of these. It could do some damage, but the valve is still functional. It's just being held shut by the pressure. So if you were to turn that off or the pump fails, typically the aortic valve still opens up and operates as it did before. Does that answer your question? Kelsey, go ahead.
So like how, once they remove the LVAD, because it's technically supposed to be like temporary,
Right.
what happens when they take the pump out of the left ventricle? Like, do they, I would assume with the aorta, they try to use like a homograft or something, but how do they do the myocardium?
I think they would just sew it up. Yep. So I'm not that familiar with these devices because I didn't scan in a hospital setting. I scanned in a clinic. And again, these patients are kind of terminal patients anyway overall. I don't know how many of these come back from having an LVAD to coming back to relatively normal lifestyle. Okay. And why do they do it? I don't know if they do it for, waiting for an actual heart transplant. Typically it says here that you don't get, you get this because you couldn't get a transplant. So maybe it's a temporary thing until there is a heart transplant. So that's obviously one way to correct it. Alternatively, there's not really many options beyond that, but they could seal it off. They could sew it up. It's unlikely the function is going to come back. Maybe they're doing this as a transplant patient where they might be harvesting other organs. Okay, just keeping the person alive for the meantime. I'm not sure the exact details around that. Okay. So mitral valve opens and closes, aortic shut. Again, look for that large bore cannula. So you're going to see this device coming into the apex. It looks really odd. What we want to see there is that the heart's not collapsing in on it. So because if you put like a suction into something, just like when they stick the needle in your arm to do the vaccine, for example, they're supposed to pull it back for a second to see if there is blood coming into it because you want to see if you're in vessel versus tissue. If you're up against tissue and you try to suck it out, it's going to just suck the tissue into it and block it. If you've ever eaten at Dick's downtown, the burger place, if you've ever had those great, awesome, super awesome peach shakes, I love them. But I hate it when I'm sucking and a chunk of peach gets stuck in my straw. I love it when it pops through and I can enjoy the flavor, but it blocks the flow, right? So we don't want that cannula pressing into a wall or the volume of the heart being so low that it collapses in on the end of that cannula. That's obviously problematic. So those are things that we look for to make sure that it still has flow. Otherwise, we might have device failure. Okay. Not sure this is supposed to be a clip. Yes, it is. Okay, I'm going to skip over this. I'll let you guys go back and watch this. This actually just shows, I'll play it for a second, but it's going to be probably choppy. Excuse me. So all this is showing you, this is a transesophageal perspective. Long axis is the mitral valve here, and then we've got the aortic valve is just not opening. That's all that's showing. Oh, that was the whole clip anyway, so we're good. Okay, so again, we want to evaluate pump function, make sure that the ends aren't blocked, making sure that we've got, let's see, the aortic valve opening ratio of electrocardiographic beats with forward flow is sufficient to open the aortic valve. So while they're putting this in and working with it, they'll make sure that they're set correctly so that the valve is not affected by or not disrupting the flow that's supposed to be happening. Obviously, we don't want the pressure to be so large in that either that it creates such a high pressure on the aorta side that it breaks your valve and causes it to break back into the ventricle, causing a flail leaflet. That would be bad. We can assess the LVOT and LV volume. Obviously, LVOT can really be assessed in 2 dimensions, but if you're doing flow, that has to be going out the aorta to really tell you anything. All right, 300 millimeters of mercury pressure can cause failure of the valve. So again, if we increase that pressure too high, it will break the valve and it will get backflow into the aorta, which is going to totally negate the whole process. Now, is 300 millimeters of mercury a little bit, a lot? What do you think that pressure is like in the body? That's a lot of pressure. Yeah, that's a lot of pressure. We obviously need enough pressure to get blood to perfuse through the brain and kidneys and the vital organs at a minimum, but not so much that we're going to be blowing everything out. That'd be bad. There could be kinking, again, of the actual cannula. There could be development or worsening of AI. There could be thrombus or ventricular trabeculate may be clogging the end of that per se. So again, not only is it possibly the heart muscle closing in on it, but yes, if we get thrombus as well, that's obviously problematic. Typically, it's not in long enough to form a pannus, otherwise that could also be a thought process. Excessive emptying in LV can cause it to collapse down and impede into that. So we've already talked about that. If we draw out too much fluid, the whole ventricle kind of collapses in on itself like a balloon, which then plugs the end of that cannula. So obviously the flow has to be just optimal. All right. So that's leaving LVADs and coming to myocarditis. So as I mentioned before, myocarditis is an inflammation of the myocardial tissue. If it's acute, it is typically acute. It's typically caused by virus or a post-virus type of process like COVID. It can result in acute onset of LV systolic dysfunction. So you'll be seeing that, and it will be global. So it will be kind of over the whole heart as a whole. It's going to range from mild to clinically undetectable to fulminant and possibly fatal, okay, over a short course. There was a student in one of the other sonography-based programs here a few years ago that ended up in the hospital. You know, they were in probably the early 20s, and they got myocarditis, and they were hospitalized for a few days, okay? So it's not an old person's disease necessarily. It could be anybody that gets it. And it's going to knock you down hard.
Hey Scott, what does fulminant mean? I don't think I've seen that before.
Basically, fulminant is severe. It's like a sudden onset of symptoms. Okay, here it is. I actually made a note of it.
Like sudden severe appearance of disease.
Yeah, so I actually wrote it in my notes here. So fulminant is occurring suddenly with great severity. How about that?
Perfect. I can add that to my notes.
Good. All right, so not all patients are going to have evidence of antecedent acute febrile and presumably viral illnesses. So in other words, they're not going to have preceding the echo, they're not going to have all that, all those signs and symptoms necessarily. They present with tachycardia, hypotension, and shortness of breath. AFib is not uncommon in these cases. Majority of patients will have some degree of function recovery, but are left with some residual dysfunction afterwards. So again, it's kind of acute onset. It could happen in somebody of any age. Basically, they're going to have really crappy EF. There's probably going to be inflammation of the muscle, so you would expect to see a little bit thicker walls potentially. That's pseudo thickness. In 2D, we're going to look for acute normal dimensions of the heart itself with global decrease in systolic function. They might have some regurgitation. Visceral pericardium may be inflamed, causing small pericardial effusion also. So I would almost expect to see at least a little bit of fluid collection around the outside of the heart also. The therapy, what they'll do is they'll do afterload reduction with diuretics and other modes of therapy. Lymphatic and giant cell myocarditis may present predominantly with the anterior wall and the right ventricular involvement. So that was just a specific note for a specific pathologic process. It is one to note. I'm not going to test on it necessarily, but that could be certainly a registry type of question. Or something that makes you look super good in front of the docs when they ask those random questions to other medical residents, and the echo tech comes up and beats into it. Okay, so LV size and function, including the LV volumes and the EF, is what we're going to be looking at. Dopplers will do Doppler tissue velocities will be blunted in acute myocarditis, but will be increased towards the normal values in underlying disease process after recovery. So in other words, it's going to look significantly like diastolic dysfunction, but it becomes recoverable after they get recovered and brought back to normal. Again, just to put the visual in there, it's nothing you have to necessarily know. It's just the myocarditis and just kind of overlaps in that, but you don't have to know that. I just needed a picture. All right, pheochromocytoma on catecholamine storm. Let me move this for a second. All right, so pheocytochromoma is rare, usually non-cancerous benign tumor that develops in cells in the center of an adrenal gland. You have adrenal glands above each kidney. Your adrenal glands produce hormones that give instructions to virtually every organ in the tissue and body. If you have pheochromocytoma, and adrenal release hormones that cause the persistent or episodic high blood pressure. If left untreated, it can result in life-threatening damage to the body, especially the cardiovascular system. So most people with it are between the ages of 20 and 50, but the tumor can develop at any age. Surgical treatment is used to remove the pheochromocytoma, which then returns the normal pressure back to normal. That's kind of what that is. So again, they'll cut it out and allows that to change back to normal. Other causes of acute severe systolic dysfunction include acute toxic exposure, such as venom from insect bites. So just a note on masses, we'll get to that chapter later, but when you see OMA on the end of a term, that's usually a mass, and it's usually a benign mass. We'll talk more about that as we get in the mass section. All right, peripartum. So around the time of delivery, they might have some cardiomyopathy signs. There will be some ventricular dilation, possibly some systolic dysfunction, and secondary mitral regurgitation. So again, this is usually somewhat temporary because it's during that time when babies, just before it's delivered to after, and we still got an extra fluid volume that the heart's having to have that extra workload for. Most after delivery, but some of them occur late in the trimesters, which is again just the weeks before birth. It can be linked to preeclampsia and possibly virus. Ranges from mild to fulminant. Here's that word again. Early stages of it have near normal chamber sizes, and diagnosis is made with cardiomyopathy first noted in the peripartum period. It's a good alliteration for you. Okay, last slide here. So we've got this trympanosoma cruzi. I don't know how you pronounce it effectively, but that's close. That's an infection. It's a parasite. So it's results in a narrow neck apical aneurysm. Most commonly presented in global ventricular dysfunction, which mimics post-viral myocarditis or idiopathic cardiomyopathy. It is endemic to South America and rarely is encountered without travel to an endemic area. So it can happen in other places, but most often in patients that have been to South America. It is I believe it's a parasite. It is, and it's typically found around that area. But it's a type of myocarditis, so it's going to present similar to the other ones. But how are you going to find this out? Often when patients are very symptomatic of things, especially if you're looking at possible infections, we want to know if they've traveled anywhere outside the US. And it's also always important to find out what area they're in specifically. So if we found out they're in South America, this would certainly put it higher on our list of, of possibilities. If they've been to like Africa or something else, we might be thinking it's some other type of parasite or disease process. But it's important to find out what that is so they can treat it effectively. Looking at the pictures at the bottom, so it basically is a parasite that's found in that bug. Let me move this, I got a little note on it. I'm trying to move my Zoom thing here. Okay, so this was a disease that was found in 1909. Okay, it's found by that that parasite that's transmitted to animals and people by insect vectors, and is found only in the Americas, mainly in rural areas of Latin America, where poverty is widespread. Chagas disease is what this is also referred to as American trypanosomiasis. I'm not going to test on that. This is informational. In the United States, Chagas disease is considered one of the neglected parasitic infections, or NPI. It's a group of 5 parasitic diseases that has been targeted by the CDC for public health action. So it's widespread enough that the CDC is doing more study and stuff on it to try to figure out what we can do with it. But it can cause heart problems, in short. So as an ecotech, let's look at the walls. Let's look at the myocardial function, our size and dilation. We're going to be looking at diastolic functions, systolic functions to see overall how things are going. And that is the end of dilated cardiomyopathies. And for my purposes, I am putting non-compaction as part of the dilated series. Even though it may, when you're in clinic, you might find that some cases of it are considered hypertrophic because it looks thick. How was that? All right, so let's take a quick bio break, and then I'll make sure that these guys are good in the other room. They're going to present from the school today, but it will be recorded, and we'll get into the 136 stuff. So,
Hey Scott, I have a quick question before we move on. It's not related to this. It's actually related to the rest of our quizzes.
Okay. In Echo?
Yeah, for this class.
Okay.
Let me find it. So we have 2 quizzes that are scheduled on the same day, and I don't know if, I'm sure that was a mistake, but on Canvas, like diseases of the aorta is on the 2nd, and then masses and tumors is also on the 2nd.